section of dentistry and more. Today we are going to discuss the previous year question paper that has comes under the topics endodontic instruments, internal anatomy, access cavity preparation, irrigation and intracanal medicaments, working length determination and cleaning and shaping of root canals. Now we are moving to the first chapter, that is endodontic instruments. The long essay is classify endodontic instrument, add a note on standardization of endodontic instruments and mention the rotary endodontic files. And the short essays includes explain ISO classification of endodontic instruments, add a note on piezo reamer, and standardization of root canal instruments, describe in detail about H-file, and last one is ultrasonics and endosonics. Short notes includes instruments for access cavity preparation and instruments for cleaning and shaping of root canal system. Now we are moving to the classification of endodontic instrument. So this is according to, first one is according to function, and it includes exploring instruments, debriding instruments, shaping instruments and obturating instruments, and these are the examples. And next one is according to use, method of use, that it includes, that is group 1 hand use only, files, reamers, spreaders, etc. And group 2, that is latch type, engine driven. It is similar to group 1 but it also includes fillers. And group 3 is drillers or reamers, latch type, engine driven, that is Gates Glidden drills, piezo reamers. And last one is group 4, that is root canal point, silver point, GP, that is power point, paper point, etc. This is the standardization of endodontic instruments. So in the figure you can see there is specification of for an endodontic instrument, that is D0. So here, and that is the diameter at the tip, that is hundreds of millimeters, that's expressed in hundreds of millimeters. And next one is there is here from D0 to D16. So it is the diameter in hundreds of millimeters at the end of the cutting blade, that is 16th meter from D0. And next one is taper of the instrument from D0 to D16, that is in increments of 0.02 mm in width per millimeter of length. And next one, the tip of the instrument should be 75 to plus or minus 15 degree. So this figure is very important, you can note it. Next one is piezo reamers. So it is similar to that of the Gates Glidden drills, but it is different from blades that is spread over a wide surface and the shape is cylindrical in shape. So these are an rotary instrument that is mainly used for post space preparation, and its tip diameter is 0.7 to 1.7 mm, and it is usually used in brushing motion. So in the figure you can see it's a representation that is showing difference in head designs of the piezo reamers and Gates Glidden drills. Next one is uses. So as we have discussed in the early slide, it is commonly used for post space preparation when these gutta perches have been removed from obturated root canals, and it also have disadvantages like it does not follow the canal curvatures and it may cause perforations, and they are stiff instruments and they are used very carefully to avoid iatrogenic errors. So in the figure you can see 1 to 6 numbers piezo reamers from the tip diameter, that is 0.7 to 1.7 mm. Next one is H-file. So it resembles like a triangles that is set one above the other, and so it is made by cutting spirals that grooves into round tapered or steel wire in the same manner as wooden screws are made. So this results in the formation of a sharp edge which cuts on removing rocks only. So it's cut only when the instrument is withdrawn because its edges faces handle of the instrument. So it is used in torquing motion. And this rake angle and distance between the flutes are the two main features that determines the working of the file. And if this edge file has a positive rake angle, that is, its cutting edge is turned in the same direction in which the force is applied, which makes them to dig into the dentine, and thus more aggressive is the cutting. Next one is advantages. So it has a better cutting efficiency and it pushes the debris coronally. And the disadvantages includes it lack flexibility, it tends to fracture, and it is an aggressive cutter. And this is the figure that is showing the edge file. So in the figure you can see that recessive or successive triangles that is set above one another. Next one is modification of the edge file. It consists of three types, that is safety headstone file, A file, and also S file. Next one is the instruments for assist cavity preparation. It includes endodontic explorers, endodontic spoon excavator, and assist opening burrs like diamond round burr, transmental burrs, endo Z burr, and tapered diamond burr. And these are the figures showing. First one is rounded carbide burr, next one is transmetal burr, X-gate, and also ultrasonic instruments. Now we are moving to the classification of endodontic shaping instruments. That is, it consists of four groups. First one is group 1, hand operated. That is, there includes K files, H files, etc. And group 2, that is low speed SS endodontic instruments which latch type attachment. It includes piezo reamers and also gate Glidden drills. And group 3 consists of sonic and ultrasonic instruments, and group 4, that is engine driven nickel titanium endodontic instruments. It's most commonly used one, that include rotary instrumentation, reciprocating instrumentation, and canal adaptive instrumentation. And next one is sonic handpiece. So it is attached to a normal airline. In other words, the sonic instruments that is used compress the airline at a pressure of 0.04, which is already available in a dental unit setup as its source of power. So it has an adjustable ring that has gives an oscillating range of 1500 to 300 cycles per second. And there are two options for irrigating the root canal while using the sonic handpiece. That is, either the water line of the dental units can be attached to the sonic handpiece, or the water can be cut off and the dental assistant can introduce the sodium hypochlorite from the syringe. And it has two type of files, that is heliosonic, shaper sonic, and also Rispic sonic. All these instruments have a safe-ended non-cutting tip with 1.5 to 2 mm in length, and the size ranges from 15 to 40. And they are used mainly in case of step-down technique. And these are the advantages and disadvantages. So some of the advantages are better shaping of the canals, and due to the consistent irrigation there is less chance of debridement. And last one is it produces clean canals, that is free of smear layer and debris. And the disadvantages includes walls of prepared canals, they are rough, and the chances of transportation is more in curved canals. Next one is ultrasonic handpiece. So this ultrasonic that is used in case of endodontics is called as endosonic. So there is based on the system on which such an energy source that activates on endodontic file, resulting in 3D activation of the file in the surrounding medium. And it uses K file as an canal instruments. So these irrigants are emitted from the cord on the power source, and it is travel down to the file into the canal to be energized by the vibration. Next one is the advantages and disadvantages. So you can see any advantage or disadvantage. And next one is mechanism of action, that is cavitation. It is defined as the growth and subsequent violent collapse of the small gas filled pre-existing homogeneity in a bulk fluid, and this motion results in development of shock wave, increased temperature and pressure, and free radical formation in the fluid. So now is the uses of endodontics. Some of endosonics, that is SS enhancement, orifice location, irrigation, sealer placement, gutta percha obturation, and also MTA placement. And this concludes the first chapter, that is endodontic instrument. Now we are moving to next section, that is internal anatomy. And from this chapter only a short essay can be asked, that is discuss the lateral and accessory root canals and highlight its importance in endodontics. So this accessory canals is a canal that branches from the main root canal. So the mechanism of formation is commonly it is unknown. So they are likely to occur in areas where there is premature loss of root because of the cells that is induced in formation of the odontoblast that form the dentine. It also occurs when the developing root encounters blood vessels where the hard substance is not deposited. And these accessory canals, they can be seen in the apical 1/3, but it also occurs in bifurcation and also trifurcation in case of multi-rooted teeth. And this lateral canal, it is also an accessory canal that is located approximately right angle to the main root canal. And its mechanism is the pulp tissues that is lying within the dentinal enclosure of the accessory or lateral canal, and when this pulp is removed, the blood vessels that is lying within the accessory or lateral canal, they are sealed or obliterated by cementum, and unless the injury occurs, whether mechanical, chemical or bacterial, with increasing age, the accessory foramina diminishes in number because of the calcification of the contained soft tissue. So as the periodontal disease progresses down to the root surface, more of the accessory and lateral canals, they also get exposed to oral cavity. So it is very difficult to identify the lateral canals on radiograph. So this is the figure showing the lateral canal and accessory canals. So you can note the figure. Now we are moving to next section, that is access cavity preparation, and the probable long essays are, first one is define access cavity, what are the principles to be followed during access cavity preparation, and describe access cavity preparation for upper central incisors. And the short essays, short notes includes laws of access cavity preparation. Now we are moving to first question, that is access cavity preparation definition. It is defined as an endodontic coronal preparation which enables, first one is unobstructed access to canal orifice, straight line access to apical foramen, complete control over instrumentation, and accommodate obturation technique. So these 4 points are very important. Next one is principles of access cavity preparation, and that is by G.V. Black. The endodontic coronal cavity preparation and endodontic radicular cavity preparation is the, in case of coronal cavity preparation, it includes outline foam, convenience foam, removal of any remaining caries dentine, and toilet of the cavity. And the endodontic radicular cavity preparation includes outline foam and convenience, resistance and retention, same as that of the coronal cavity. So first one is endodontic coronal cavity preparation. So the outline foam of an endodontic cavity, it must be correctly shaped and dispositioned to establish the complete access for instrumentation. And the 3 factors includes are, first one is the size of the pulp chamber. That is, young patients it is extensive, and in old patients it is very much limited. And the shape of the pulp chamber, like anterior it is triangular, premolar it is oval, and polar it is also triangular. And the number and direction of the root canals. Next one is convenience foam. So it also contains such points like unobstructed access to canal orifice, direct access to apical foramen, like that, and removal of any remaining caries dentine, that is the elimination of bacteria, discolored tooth structure, possibility of any coronal leakage, and cleansing of the cavity, that includes all the caries, debris and necrotic materials that can be removed from the pulp chamber before the radicular instrumentation begin. So here mainly used is sodium hypochlorite. And next one is retention foam, that is the used to prevent the apical leakage and resistance. It is provided by maintaining the integrity of natural construction of the apical preparation. So it also prevents over instrumentation. And now we are moving to the laws of SS cavity preparation, and there are 6 laws. And the first one is law of centrality. So here the figure you can see the law of centrality, that is the floor of the pulp chamber. It is always located in center of the tooth at the level of the CEJ. And second law is law of concentricity, that the walls of the pulp chamber, they are always concentric to the external surface of the tooth at the level of the CEJ. And the second figure shows the law of concentricity. And next one is law of CEJ. So in this you can see the figure, that is the distance from the external surface of the clinical crown to the wall of the pulp chamber, the same throughout the circumferences of the tooth at the level of the CEJ. And the fourth one is law of color change, that the color of the pulp chamber floor, it is always darker than the walls. And the law of symmetry 1, that is except for maxillary molars, the orifice of the canals, they are equidistant from the line that is drawn to mesiodistal direction through the pulp chamber floor. So in the last figure you can see the law of symmetry. Next one is law of symmetry 2, and the except for maxillary molars, the orifice of the canal, they lies on line that is perpendicular to the line drawn on the mesiodistal direction across the center of the floor of the pulp chamber. So there are total 9 laws, and the 7th one is law of orifice location 1, 2, and 8th one is location 2, and 9th one is location 3. So in case of location 1, this orifice of root canals, they are always located at junction of the walls and the floor. And in case of location 2, they are located at at an angle in the floor or wall junction. And location 3, the orifice of the root canal, they are located at the terminuses of the root developmental fusion lines. So these are the figures that showing the law of orifice location 1, 2, and 3. Next one, in case of maxillary central incisor. So this shape, size, and coronal extension of the pulp chambers, they are estimated from the diagnostic radiograph. So here the enamel, it is penetrated in the center of the lingual surface at an angle perpendicular to it with number 4 round burr. And this burr, it is directed along the long axis of the tooth until the pulp chamber is reached. A drop on the burr into the chamber may be felt if the chamber is large enough, and any overhanging enamel and dentine from the palatal roof of the pulp chamber, they are removed, including the pulp horn. And by using this small number 4 round burr and slow speed contrangle from inside to the outside, a straight line penetration to the apical root canal will be achieved. And a gate Glidden drill of appropriate size or any other suitable orifice enlarged is used to remove the palatal shoulder by working from inside to outside with the light strokes. And this palatal shoulder, it is a prominence of dentine that it must be removed, and the labial bevel, it must be given, and the access verified by endodontic explorer into the canal orifice. So this is the figure. In the first figure you can see the initial point of entry of the burr, that is in middle third of the palatal surface. And in the second figure you can see round burr that is perpendicular to the long axis of the tooth is kept. And in the third, see that is burr, it is directed at 45 degree to the long axis of the tooth in order to penetrate into the pulp chamber. So here you can see the burr is placed at 45 degree. And in the fourth figure, the removal of the chamber roof can be seen. And in case of final access cavity shape of maxillary central incisor, so you can see in case of figure F and also G, access cavity shape of maxillary lateral incisor can be seen. And this includes the assist cavity preparation. Now we are moving to irrigation and intracanal medicaments. So this is a very important chapter, and there will be long essays like classify root canal irrigants, mention the role of irrigants in the success of endodontic treatment, add a note on chlorhexidine as an irrigant, discuss about the ideal requirement classification and recent development in root canal irrigants, enumerate various root canal irrigants and discuss the ideal requirement, write a note on recent advances in root canal irrigants, and the short essays include classify various intracanal medicaments, add a note on role of the intracanal medicaments in endodontics, enumerate the intracanal irrigants, advantages and disadvantages of sodium hypochlorites, and short note includes intracanal medicaments. All these are repeated questions itself. So first one is ideal requirements of intracanal medicaments, and so you can read or give any of this. It has an antimicrobial activity and it mechanically flushes out the debris from the root canal. So here there is 8 or 9 requirements, so this must be thorough. Next one is classification, Grossman classification. Its most commonly used irrigants are sodium hypochlorite, EDTA, and chlorhexidine digluconate, and the recently introduced are HEBP, sodium potassium iodine potassium iodide, and the antibiotic containing irrigants. And based on the chemical activity, that is chemically inactive solution, and also there is chemically active materials. Inactive includes water, saline, and local anesthetic, and the active materials, that is acid, alkaline, antibacterial agent, chelating agent, oxidating agent, detergents like that, enzymes like trypsin, streptokinase. And next one is objectives of irrigation, that is used to remove the debris that is created during shaping of the root canal and lubricate the root canal, dissolve organic and inorganic tissues, and remove and prevent the formation of the smear layer. Next we are moving to sodium hypochlorite. So it is a reducing agent, and its properties are it is clear, straw colored, and it contains 5% of available chlorine. It is most widely used irrigating solution, and its mechanism of action is that on ionization it may produces hypochlorous acid and hypochlorite ion, and so these are responsible for the antimicrobial ability, and this destruction of the bacteria they can be takes place in two phases, that is penetration of the into the bacterial cell wall and chemical combination with the protoplasm of the bacterial cell and disruption of the DNA synthesis. And its mechanism of action can be due to the saponification reaction, amino acid neutralization, hypochlorous acid formation, chloramination reaction, and high alkaline pH that will be greater than 11. And drawbacks of sodium hypochlorite, that is includes it may causes cytotoxic effects on healthy periradicular tissues during irrigating procedures, and it has an unpleasant taste, and when it is kept in cool space, it should be kept in cool space away from the sunlight. Next we are moving to chlorhexidine digluconate, that is 2%. It is a cationic bisbiguanide which is utilized as an irrigating solution as well as intracanal medicament. So it consists of two symmetric 4 chlorophenyl rings and two bisguanide group that is held together by a central hexamethylene chain. So it is less toxic when compared to other irrigants. Its mechanism of action is it has a broad spectrum antimicrobial activity, and this 2% it is capable of electrostatically binding to negatively charged bacterial surface, and it has the ability to penetrate the bacterial cell wall, and it causes the coagulation of the cytoplasmic components. So it is effective against the E. faecalis, which is one of the most important pathogens that is identified in root canal filling teeth that is exhibiting clinical failure. and limitations that include it lacks the tissue dissolving ability, it does not remove the smear layer, hence it has to be employed in conjugation with other irrigants. And the recently introduced irrigants are, first one is HEBP, that is hydroxy ethylene 1,1 bisphosphonate. So it's a weak chelator and it is potentially alternative to EDTA, and it does not interact with sodium hypochlorite and it can be used in conjugation with that. So this combination can potentially remove the endodontic smear layer. So it is commonly used in case of canal shaping procedures. Next one is iodine potassium iodide. It is a broad spectrum antimicrobial irrigants that is used in a concentration of 2 to 5%, and this disadvantage is it may be allergic or it produces allergic reaction to some patients. Last one is antibiotic containing irrigants. So you can see Qmix, that it is a Qmix, it contains two types, that is type 1 and type 2, and it is recommended to be used as a final rinse after sodium hypochlorite as an irrigant for antimicrobial and also smear layer removal properties. Advantages is it is less demineralized to dentine when compared to EDTA, and it does not cause any erosion of dentine like sodium hypochlorite when sodium hypochlorite is used as a final rinse after EDTA, and the functions, it may penetrate into the biofilm and will kill 99.99% of the bacteria. Last one is oxygenated water irrigation. Advantages, it is a powerful antimicrobial agent, and there is lack of mucogenicity and high potency. The intracanal medicaments classification. The classification mainly include, first one is essential oils, that is eugenol, phenolic compound, that is phenol, aldehydes like formocresol, paraformaldehyde, glutaraldehyde, calcium hydroxide, halogens like chlorine, sodium hypochlorite, iodine, and chlorhexidine gluconate, antibiotics, and corticosteroid antibiotic combination. Now we are moving to the functions of intracanal medicaments. So it may destroy the remaining bacteria and it will limit the growth of new arrivals in case of apical periodontitis. For example, in case of inflammation caused due to over-instrumentation. And indications of using intracanal medicaments, that includes it removes the remaining microorganisms from the pulp space and it dries the weeping canals and neutralizes the tissue debris. And this concludes the irrigation and intracanal medicaments. Now we are moving to working length determination, and this is also very important chapter. The long essays include the importance of working length determination, various methods for determining the same, add a note on electronic apex locator, and short essay include define working length, same as the above, various methods, and explain non-radiographic method, and also add a note on Ingles method for working length determination, and the short notes includes working width and also Ingles method. So these are all repeated questions only. So this working length definition, it is defined as distance from the coronal reference point to a point at which the canal preparation and obturation should terminate. And the significance, so here the significance of the working length, it is commonly asked question, so you should be thorough with the same points. And there is consequences for overextended and also underextended. In case of overextended, there will be first one is perforation through apical constriction, there is over instrumentation, over filling, and there is post-operative pain, prolonged healing period, and lower success rate. Case of short working length, there will be incomplete cleaning and instrumentation, there will be discomfort under filling of the root canal, incomplete apical seal, apical leakage that support the existence of viable bacteria that may leads to poor healing, and also periradicular lesions can also occur. Next one is method of determining the working length, and mainly there are three methods. First one is important, that is electronic apex locator. Next one is radiographic methods like Ingles technique, others like Best method, Breckman's method, Grossman's method, Cutler's method, X-ray grid method, zero radiography and direct digital radiography, and non-radiographic methods like tactile sense, apical periodontal sensitivity, and also paper point method. Okay, so first we are moving to this electronic apex locator. And the electronic apex locator, and this have been developed for determining the working length of the root canal without distorting the radiograph. This in the recent years. So currently the electronic apex locator, it is the most optimal and accurate method for establishing the root canal working length, and the concept is that by comparing the electrical impedance of the periodontal membrane with that of the oral mucosa, both of which should be similar to 6.5k ohms. And the components of the electric apex locator include lip clip, file clip, electronic device, cord which connects the above three parts. And the advantages includes some of the advantages to provide objective information with high degree of accuracy in reading, and also they are available in combination with the pulp tester. It can be used in case of pulp vitality test. And the disadvantages are also there. It produces inaccurate reading in case of all this, that is presence of any pulp tissue, too wet or too dry canal, blockage of any canal, low battery, and there is chances of overestimation, and incorrect reading in case of teeth with periapical radiolucency, necrotic pulp, root resorption, like that. Next one is uses of apex locator. So it provide objective information useful in conditions like impacted teeth, zygomatic arch story, excessive bone density, overlapping roots, and shallow palatal vault. In case of pregnant patients, to reduce the radiation, so it can be used, and in useful in children who cannot tolerate the radiograph, can also used in case of disabled patients and the patients who have heavily sedated. Next one, it is an available tool for detecting the site for root perforation, diagnosis of external and internal resorption, and detection of any horizontal or vertical root fracture, and determination of any perforation, pulp vitality testing, helpful in case of root canal treatment with incomplete root formation, apexification. And its contraindications include it is contraindicated in patients with who have cardiac pacemaker, and the electric stimulation to such patients, it would interfere the pacemaker function, but this problem have been overcome in fewer generations of the apex locator. There are many generations, and now we are moving to the classification of electronic apex locator, and it is based on type of the current flow and opposition of the current flow, as well as number of frequencies involved. And the basic conditions for the accuracy is canal should be free from debris, it should be dry, there should be no cervical leakage, no blockage or calcification in the canals. Now we are moving to the first generation. It is also known as resistance apex locator, and it measures opposition to flow of the direct current, and it's based on the principle that resistance offered by this periodontal ligament and the oral mucosa membrane is the same, and it contains advantages and disadvantages. Second generation, it measures the opposition of flow of alternative current or impedance, and it indicates the apex when two impedance values approaches each other. Here also there is advantages and disadvantages. Third generation, and it is based on the fact that different sites in canal gives difference in impedance between high or low frequencies, and as the probe goes deeper into the canal, there is difference increases and it is greatest at the cemento-dentinal junction. And the fourth generation, that it measures the resistance and capacitance separately rather than the resultant impedance value. So there can be different combination of values of capacitance and resistance that provide the same impedance, thus the same reading. And but by using this fourth generation, it can be broken down into primary components and it measures separately for better accuracy and thus less chances of occurrence of the errors. Now we are moving to non-radiographic methods. First one is digital tactile sense. So in this, the clinician may see an increase in resistance as file reaches the apical 2 to 3 mm, and the advantages includes it is time saving and no radiation exposure. And there is also disadvantages. Sometimes it does not provide the accurate reading, and in case of any narrow canals, there will be increased resistance as the file approaches apical to 2 to 3 mm. And this, in case of immature apex, these instruments can also go periapically. Next one is periodontal sensitivity test. So it is commonly used when the patient responds to pain. It is based on that, and this is not always used that it does not provide an accurate reading. In case of necrotic pulp, the instruments can pass through apical constriction, and in case of vital or inflamed pulp, the pain may occur several mm before the periapex crossed by the instrument. And last one is paper point measurement method. In this case, this paper point is generally pressed into the root canal to estimate the working length. So it is a supplementary method. And now we are moving to Ingles method. So it is a radiographic method for working length determination. Here you can see the Ingles method. That is, first one is the diagnostic radiograph. It is estimate the working length of the tooth by measuring the tooth from the stable occlusal reference point till the radiographic apex, and then subtract at least 1 mm from this length as the minor constriction is always present short to anatomic apex condensation of the radiographic image. So here 1 mm is cut, and the next figure shows this measurement is transferred to the diagnostic instrument with a silicone stop which is placed at the root canal, and working length radiograph is taken. So here you can see this stopper is used, and on the radiograph measure the difference between the end of the instrument and radiographic apex of the root. The tip of the instrument ends 0.5 mm to 1 mm from the radiograph root apex, and if the short of the radiograph apex occurs by more than 1 mm, add this value to the early estimated length and adjust the stopper on the diagnostic instrument according, and then retake the working length radiograph. And if it goes beyond the radiographic apex, then reduce the value from the early estimated length, and it is adjusted stopper on the diagnostic instrument accordingly, and it is the working length radiograph, it is retaken. So this is the Ingles method. Next one is working width. So it is defined as initial and post instrumentation horizontal dimension of the root canal system at working length and other levels, and the minimum initial working width corresponds to initial apical file size which binds at working length. And the guidelines includes that enlarge the root canal at least 3 size beyond the first instrument that binds the canal, to enlarge the canal until it is clean, and it can be indicated by which the dentinal shaving on the instrument floats. And now we are moving to the factors affecting size of the working width, that is whether the root canal is vital or non-vital, there is presence of any periapical pathology, presence of or absence of root absorption, and if the canal is C-shaped canal, absence or presence of isthmus. And now the reasons for widening root canal: to remove the microorganism from the canal, and to increase the area of the root canal for better irrigation, to completely remove the pulp tissue, and to round shape confirms the round cross section tip of the gut aperture. And this concludes the working length determination. Now we are moving to cleaning and shaping of root canal. And there will be short essays and short notes. And short essays include enumerate various parts of endodontic file and describe crown down technique. And the short notes include balanced force technique, crown down preparation, Schilder's objective, step back technique, and recapitulation. First one is crown down or step down technique. Here the patency of the canal, it is first established with the size of 8 or 10K file, and the procedure includes the preparation of any coronal 2/3 of the canal by using headstone file or H file, and this working length of 16 to 18 mm or to the point where the file starts binding, and after that it is followed by flaring the coronal segment of the canal with the help of Gates Glidden drill number 3, 2 or 3 or sometimes 4 can be used. And while using this, the care should be taken so it is used away from the furcation to avoid the strip perforation. And the next phase involves apical instrumentation with a small size, that is 10 or 15K file, that is followed by working length determination. After that, a large file, K file, that is size of 60, it is placed into the canal to level of binding, and the canal it is instrumented using a watch winding motion until this resistance is encountered. After that, the process is repeated with a subsequently smaller files until the working length is reached, and the recapitulation with the size of 10 or 15K file in between each change of the instrument. The apical next one is the apical portion of the canal. It is now enlarged to the appropriate master apical file, which could be vary from canal to canal or from tooth to tooth. And the final canal taper, it is accomplished by the master apical file, that is used in a circumferential filling motion. And this technique, it has many advantages, that includes first one is shaping of the canal. It will be easier than the step back technique, and there will be removal of the coronal obstructions that allows the removal of bulk of tissues like debris, microorganisms, and it minimizes the extrusion of the debris through the apical foramen, so that it will prevent the discomfort, post-operative discomfort, and it will also allows an assist and control over the apical enlarging instrument, so it will decreases the incidence of zipping, and it also better penetrates into helps in the penetration of the irritants. So this is the systematic representation of the crown down technique. Now we are moving to crown down pressureless technique. In this, that is early coronal flaring with Gates Glidden drill. It is followed by an incremental removal of the dentine from the coronal to the apical direction. Hence it is called crown down technique. And the straight K file, that is used in the large consequences in a reaming motion, and here no apical pressure, so it is called as pressureless technique. And the procedure, after the completion of the coronal access, this working length is determined, and 35K file, it is introduced into the canal with no apical pressure is produced, and after that Gates Glidden drill number 2 is used, short or to the depth explored with the size of 35K file. And now the next step of is by using number 60 file, that is with no apical pressure, this reaming action, it is employed to enlarge the canal, and it is followed by use of smaller files and deeper into the canal. And radiograph is taken, that is taken when the instrument penetrates the provisional working length, after which apical directed procedures continues until the definite working length is reached. And the final step, it is used to enlarge the apical area to the appropriate master apical size at the working length. Now we are moving to the balanced force technique. So this technique, it is described as positioning and preloading the instrument through clockwise rotation, and then it is shaping the canal with counterclockwise rotation. So the coronal third of the canal, it is prepared using the crown down technique. After that, the less pressure is inserted, and flex R or flexophile, the instrument is rotated clockwise using only a light apical pressure, and it is again rotated counterclockwise, and the sufficient apical pressure is used to keep the file in the same insertion. And in this step, the dentinal shavings are removed with a characteristic clicking sound. And after this 2 or 3 cycles, the file, it is loaded with dentinal shavings. It is removed from the canal and with a prolonged clockwise rotation. And the sequential file, they are used in the crown down before preparing the apical third to the appropriate master file size. Last, this firmly believed in enlarging apical areas to size larger than generally practiced. So a minimum enlargement of size 1.5 mm short to the apical foramen in curved canals is recommended, and size 80 in single rooted teeth carrying the preparation through the full length of the radiographic apex of the root. And the balanced force technique has shown to reduce the canal transportation and ledging. Next one is step back technique. So in case of step back technique, the canal, it is enlarged first in the apical third to an at least of number 25 or 30 instrument, and then each consequently larger root canal instruments, they are used for shaping the middle third and coronal part of the root. So the procedure include cleaning and shaping, that is begins on completion of gross debridement and determining the exact working length. After that, a size of 10 file, that is followed by size 15. It is inserted into the canal orifice, and this file, it is encased into the dentinal walls with lateral pressure and is withdrawn, and this is repeated around the entire perimeter until the walls are instrumented. And the entire canal, when it is irrigated, all the solutions and debris, they are aspirated, and the file, it is inspected for any deformation or debrided after cleaning. And by squeezing a cotton sponge around the blade while rotating the file in counterclockwise and filling the procedure, it is repeated. Once the area of the apical foramen is cleaned, the apical third of the preparation is again started. This apical third, it is serially enlarged to develop the apical stop of size 25 file. And the next step is step back preparation, which is achieved to increase the size of the file and by decreasing the length by using 30, 35 or 45 files of 1, 2, 3 or 4 mm short of the working length to produce the coronal taper. And next step is to prepare the body of the canal. Large file, it is inserted until it makes a forced contact with the walls of the canal, and the patency of the apical canal segment that has enlarged to size of 25, that must be ensured by continued use of the file. And once the body is of the canal preparation is completed, number 2 or 3 gates, glidden drills are used, and the circumferential filling using the master apical file can be used to smooth out and further refine the steps that is created by the step back. And in case large, all instrumentation is performed in combination with irrigation to prevent the blockage of the canal with dentinal or pulp debris, to prevent the forcing of irrigating solution beyond the apical foramen. And the body of the canal, it is instrumented with a list of 3 to 4 larger files with recapitulation between each size. And the instrument, it is finished once the instrumentation is finished, when the walls are smooth and cleaned, when the preparation shows continuous taper in the apical direction. So this is a figure showing. Next one is recapitulation. So returning to the smaller instrument from time to time before advancing the larger size, that helps in preventing the packing of the dentin filling, and it ensures the patency of the root canal through the apical foramen. So in other case, in other words, the recapitulation means the repeated reintroduction and reapplication of the instruments previously used throughout the cleaning and shaping process in order to create well-designed, enclosed, smooth and evenly tapered step-less root canals. And this entire procedure is also called as serial trimming and filling and constant recapitulation. Next one is Schilder's objectives. It consists of mechanical objectives and also biological objectives. In case of mechanical objectives, it should have a continuous tapered conical shape with the narrowest cross-sectional diameter apical and the widest diameter coronally. And the walls, it should taper evenly toward the apex and should be confluent with the access cavity to give the prepared root canal the quality of flow, that is shape that permits the plasticized gutta percha to flow against the wall without impedance. And it should keep the apical foramen as small as possible, and it should shape and clean the canal without transporting the apical foramen. Next one is biological objectives, that is the confinement of instrumentation to the root themselves and ensuring that the necrotic debris are not forced beyond the foramen, and there is removal of all the tissues from the root canal space. And last one is creation of significant space for optimal obturation of the radicular space. And this concludes the cleaning and shaping of root canal. So here ends the few topics of conservative dentistry and endodontics question paper. Hope you all understood this section, and we will come back with another section, and thank you all.